This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, a 70-year-old diabetic lady has this hypermature hard cataract with a moderately dilating pupil, and it's a complex case. Now, because the pupil is reasonably well dilated, it's not very well dilated, but it's alright. I thought I could manage this. The incisions are made, the capsule is stained, dispersive OVD is placed into the bag, and now we have a slightly better dilatation. So time to perform the rhexis. Now this is a hard cataract, so I want to have a slightly bigger rhexis so that nucleus management would not be so stressful on the rhexis edges. So I have a decent sized rhexis done, and now is the time to perform the nucleus management. Now usually I avoid doing hydrodissection in these mature cataracts, but this was a sclerotic cataract and I was expecting some capsulocortical adhesion, so I'm just using the hydrodissection cannula to nudge and see whether the nucleus is mobile. I'm injecting just a little bit fluid just to ensure that the nucleus is free from its attachment to the capsule bag. And once I am certain that the nucleus is free, time to move on to phaco. The strategy which I'm going to use in this patient is going to be a 4-quadrant technique. Time to emulsify the nucleus. Please note that the tip is exposed slightly longer than what I would have usually done for my average grade cataracts. This gives me access to the deeper part of the nucleus, and I don't have to make a very wide trench to get access to the posterior plate. So that's the idea. The sculpting is begun. I prefer to always stabilize the nucleus with my second instrument. The nucleus is rotated 90 degrees and the sculpts are repeated. The subsequent trenches are going to be much more deeper than the preceding trench. That's how it would go ahead. The nucleus is then again rotated 90 degrees. The pre-existing trench is now deepened. Rotated 90 degrees. Now is the time to create the last of the 4 trenches. Again, I want to create a slightly longer trench. Care has to be taken that we avoid injuring the distal rhexis margin in the quest to get a slightly longer trench. So jerky movements can be avoided if we can stabilize the nucleus well with the second instrument, and that really comes in very handy. Now once I realize that it's about 90 to 95% depth, I begin my lateral separation maneuver, and quickly I realize that the depth was not deep enough as I would have liked. So it was about say 85%, maybe I should have sculpted another 5 to 10% more to make it much more easier for me to crack during lateral separation. So the nucleus is rotated 90 degrees now, and again, I'm attempting the lateral separation maneuvers. At this moment, there is a slight snap. The nucleus separates, but I thought it was slightly much forceful than what I would have preferred to. This is the next lateral separation maneuver. I'm using multiple attempts to get the final crack. So this is how it has to be done. It's very controlled and gentler. So you don't have a rapid crack and it can result in a snap. So now we have got 4 free fragments. Now is the time to emulsify the nucleus. I've gone in and reduced the exposure to the tip so that it's much more comfortable to deal with the nucleus, and our second instrument has been exchanged with a Sinskey hook. The nucleus fragment is pulled out of the bag and emulsified. Time to emulsify the second fragment. So I would want to avoid or minimize lens chatter and turbulence because this is a dense cataract and I don't want it to injure the endothelium. So far so good. The followability is excellent. I don't see any problem. Before emulsifying the last fragment, I thought I will go ahead and put in OVD, and there's something suspicion happening in the background, and the moment I come out I can see a clear demarcation line. Well, this was not good. Well, there is something wrong. So clearly I can see these two lines in the posterior capsule suggesting that there is a possible posterior capsular tear, and I have got a last fragment and a PC tear. And looking at the configuration of the PC tear, doesn't look like the vitreous is disturbed as such. The anterior seems to be intact. So again, I go in and emulsify these fragments. So the last fragment is emulsified, and now because I'm aware that there's a existing posterior capsular tear, I don't want the chamber to shallow. OVD is injected from the side port before withdrawing the phaco probe. And now on retroillumination, I can clearly visualize the posterior capsular tear. Now, the million-dollar question. Now, this case was planned with a single piece hydrophobic lens, and the lens is ready. Now, looking at this PC tear, which is strategically placed, it is in the mid-peripheral region, and 2/3 of the capsule support is there quite well. So at this point, I'm just thinking, should I continue using the single piece lens and place it in the bag itself, or should I consider using a multi-piece lens with an optic capture? And third option would be, should I place a single piece lens in the bag and have a reverse optic capture, wherein the haptics will be in the bag, but the optic will be pushed anteriorly. I took a couple of minutes to decide, and looking at the configuration of the posterior capsular tear and the absence of any vitreous prolapse, I decided that I'll go ahead and place the single piece hydrophobic lens in the bag. My idea is to ensure that the haptics are placed away from the area of the posterior capsular tear. So this is the diagrammatical representation which I have in my mind. This is how the lens is going to sit. So all should be well. That is my plan. And so the strategy here is I fill in the bag with OVD, but I'm not going to place the haptics in the bag immediately, so that I don't want the haptic to directly land in the posterior capsular tear itself. So I want it to land over the anterior capsule, and then manually I'm going to introduce the haptic under the rhexis margin. That was my plan. And the lens is delivered above the anterior capsule, and then manually I'm negotiating the haptics. And I was successfully negotiating the optic and the two haptics in the bag. The right haptic is sitting exactly where I desired, but however, the left haptic has changed position slightly, and in this maneuvering, you can see that the posterior capsular tear also has enlarged a bit, and the left side haptic is coinciding with the posterior capsular tear. I'm not able to visualize the extreme periphery of the capsular bag to know whether the posterior capsule is intact in the region of the haptic, but definitely in the more proximal area that is towards me, the posterior capsule is intact. Maybe 1/3 of half of the haptic, I'm not certain about the support from the posterior capsule. Nevertheless, we can see that the posterior capsular tear size has definitely enlarged a bit. On the right hand side, the haptic is very well supported by the posterior capsule, so it doesn't seem to be an issue. So OVD is being removed from the anterior chamber now. As a routine, I would always go in and remove the OVD from behind the lens. Well, this is an exception. I don't want to go anywhere, lift the lens at all. So I'm just irrigating out all the OVD which is in front of the lens. I'm going to use diluted triamcinolone acetate just to check for any presence of any vitreous. There's none. So what do I do now? Should I leave the lens like this, or should I try a reverse optic capture, or should I exchange the lens? Because I had not expected the posterior capsular tear to enlarge or the part of the haptic to be in the danger zone. But nevertheless, at this stage, I decided that I'm going to keep the lens as it is, and I would commit myself that in the event of any decentration, I'm going to exchange the lens with a multi-piece lens and achieve an optic capture. So with that commitment, I closed the eye, and these are the first day post-op pictures. And I dilated the patient on the third day just to visualize the lens, and it was perfectly fine, very well centered, and the patient continues to do well, and we followed up for now 1 month. Invariably, these hydrophobic lenses stick onto the posterior capsule, and I haven't experienced any late onset decentration in such situations. Nevertheless, this patient would be on frequent monitoring. Now let us rewind and see actually when did the posterior capsular tear happen. So when I rewinded the case, I think the first lateral separation maneuver was not complete. But the second crack, there was a feel of a snap. It was a bit forceful, I thought. and this step probably would have caused a posterior capsule tear. That is my assumption. And when the first fragment actually came out, there is a slight waviness in the posterior capsule. Posterior capsule is already torn by this stage, but during the surgery it wasn't very clearly visible for me. But by the end the third piece was being emulsified, it is very clearly seen that the posterior capsule is wrinkling, folding, and you can see a couple of lines. So whenever we see that the posterior capsule is wrinkled as the emulsification process is going on, and if you can see these folds in the posterior capsule, these are indirect signs of an posterior capsule tear. If there was anterior rupture and vitreous prolapse would have happened, the position of the wrinkles wouldn't change. It would be just stationary and it would be enlarged, and the posterior capsule would be pushed to one side and the vitreous would have prolapsed out. Once the vitreous comes in the vicinity of the antechamber, the followability of the nucleus, everything would get affected. So that would behave in a different way. But when you see this wrinkling of the posterior capsule which is changing its position, it is a clear-cut evidence to suspect an underlying posterior capsule tear, with probably the anterior not being ruptured yet. So whenever there is a suspicion, always go in and inject OVD before coming out. Many of the beginner surgeons might find it difficult to inject OVD with the non-dominant hand. You just place the cannula in the side port, ask the assistant to push the OVD inside, and you have to turn off the irrigation. This is a small trick which should make most newcomer surgeons to inject OVD before coming out. So in the last fragment, because the anterior phase was intact and I had diagnosed it, but if you can maintain a stable chamber, you can emulsify this fragment without doing anything else. But of course, you can always do an IOL scaffold technique if you're scared the nucleus can drop off. But usually what I've found that even when there is an underlying posterior capsule tear without a vitreous disturbance, if the chamber is maintained well enough and there's no surge or fluctuation in the antechamber, you can emulsify the last fragment without the fear of dropping it. Now, of course, if there is a vitreous prolapse, the entire management protocol is going to be different. So with this video, I think we could learn how to identify the subtle signs of an posterior capsule tear with an overlying nucleus. So that was it. Thank you for watching and hope you found this helpful.